I would like to thank the Academy of Medicine and AIMS, Professor Mishra and Professor Balram Iron for this opportunity. Cardiovascular disease is indeed one of the major causes of morbidity and mortality in India. And it's not unusual for us to see this kind of headline. Young smokers get a heart attack in India at the age of 30. In fact, when we came back from dinner yesterday, we did see a lot of young smokers waiting to get into a pub. So I'm sure smoking is a major problem in France also. Heart failure, as Professor Daniel also showed, is also becoming a major problem in India. The difference is our patients are sicker, they die much faster. In fact, a study which we concluded recently showed that almost 1/3 of the patients who get admitted in tertiary hospitals like our own die within the hospital admission, and even at discharge over the next 6 months or so, another 1/3 are likely to die or get readmitted. So I'll just highlight some of these points. Coronary artery disease is a major problem in India. The disease burden is about 30 million, which amounts to about 5 to 10% of the population. Coronary artery disease, as we see in India, is much more prevalent as compared to the rest of the world. And this is true for Indians wherever they stay in the world. The difference is that the disease that we see occurs in much younger population. Disease that we see is much more malignant. So we see more of triple vessel disease, more of sudden cardiac death, and much more acute events. And the conventional risk factors that we see, like diabetes, like hypertension, hypercholesterolemia, and smoking, don't always explain the manifestation. Just to try and show you some of the data. This data from rural Kerala, which is one of our southern states, compared to China, Japan, which is some of the other Asian countries, and from the United States. As you can see, mortality data in India is much higher as compared to the other countries. Another data again showing that mortality is much higher in coronary artery disease in India. Again, data from the CADI study, coronary artery disease in India. 50% of the coronary artery disease occurs before the age of 50. The 4 conventional risk factors, smoking, hypertension, diabetes, and hypercholesterolemia, explain only half of the coronary artery disease that we see. More than half of the patients, we are not very clear what are we dealing with. So what is it that explains the coronary artery disease? We are born with a propensity towards coronary artery disease. Over that, we load the extra risk factors, which are often preventable. We have found that we have a propensity towards what is known as the metabolic syndrome. We have more of diabetes, we have more of insulin resistance. We have more of a procoagulable state, we have more of high triglycerides, we have more of a prevalence of low HDL.
Beaucoup de diabète en Inde, beaucoup de diabète, a lot of diabetes.
The Interheart study suggested that coronary disease and the risk factors are similar all over the world. But such a simplistic approach does not explain the fact that though the risk factors seem to be similar, the manifestation of coronary artery disease is not the same in India. So there have been attempts to look at other risk factors like hyperhomocystinemia, fibrinogen, and various other factors. In fact, we have also tried to look at nutritional deficiencies to see whether there can be a link between various nutritional deficiencies and coronary artery disease. So there are a number of questions which need to be answered in terms of coronary artery disease in India, areas in which collaborations can be developed. Why is it that coronary artery disease in India is different? Why is it that even with the same risk factors or even at lower levels of risk factors, we get coronary artery disease, which is much more malignant? What are the interventions which can prevent this disease to occur? Coming from coronary artery disease to heart failure, this is again some of our data. As you can see, the patients that we see in India are young. The average age is 53 years or so. The ejection fractions are low. What are the causes? Causes are ischemic heart disease, but also a significant amount of rheumatic heart disease and cardiomyopathies. When these patients get discharged, about half of these patients are discharged on beta blockers, which is much lower than what we see in the Western population. Not that because we don't want to discharge them on beta blockers, but because they're not able to tolerate beta blockers at the time of discharge. A large number of them are getting ACE inhibitors. We do use a lot of digoxin as compared to the Western studies. Almost all of them are on diuretics. What happens to these patients as compared to the Western data? In hospital mortality, 30% as compared to the optimized study, 3.8%. Post-discharge mortality, 26% as compared to 8.6%. Post-discharge events, 39% over 6 months as compared to 30%. So very high in-hospital and follow-up mortality in our patients as compared to Western data. Causes, again, ischemic heart disease, idiopathic cardiomyopathies, and rheumatic heart disease. This is in the hospital admitted patients. This is some of our hospital data when we looked at patients who are not admitted. These are the most stable chronic patients. We looked at our patients in our outreach hospitals, in some of the village hospitals. This was a study which we did in a village population where we screened about 10,000 patients who had shortness of breath but who had not come to the hospital, had symptoms of shortness of breath with or without pedal edema. There we found a prevalence of about 1 in 1,000 shortness of breath due to heart failure. There, what we found was that uncontrolled, undiagnosed and untreated hypertension was the commonest cause of hypertension. So these are patients who were being treated with bronchodilators for shortness of breath. The hypertension had not been picked up. They had not come to the hospital. So these were people in the villages. So there, in this rural setting, the commonest cause of heart failure was hypertension. The third group was patients who had come to our OPD with heart failure. There, because we were sitting in a tertiary care hospital, the rheumatic heart disease became the most commonest cause of heart failure. So rheumatic heart disease was the commonest cause, then ischemic heart disease, then other causes like hypertension, cardiomyopathies. So 3 different settings, 3 different causes, but ultimately rheumatic heart disease, ischemic heart disease, and hypertension remain the most common causes of heart failure that we see. Looking at the burden, now the total burden of heart failure in Europe is about 14 million. Our estimated burden of heart failure all over India comes to about 10 million itself. So a very big burden of heart failure in India. I've already highlighted some of these, so I'll skip this slide. So just to summarize, the coronary artery disease that we see, the patients are younger, the risk factors are similar, but that itself does not explain why the disease that we see is more malignant and more diffuse. Heart failure, again, the disease is much more malignant, occurs at a much younger age group. Valvular heart disease, ischemic heart disease are the most common causes. When we talk of the manifest disease that we see, that is actually like the tip of the iceberg. We have to treat the disease that we see, but it's more important to try and prevent the disease. You can't just keep treating the disease, you have to try and prevent the disease by looking at the risk factors. And perhaps that's where we need to try and combine what is perhaps our ancient wisdom and perhaps what we need is from the Mediterranean and the French cuisine and the Mediterranean diet. We already know that that is how the initial discovery of the Mediterranean diet took place. An observation that the Mediterranean diet, the people were actually eating what looked like a rich diet, a diet which was actually rich in vegetables, olive oil, fruits, and red wine. But the people were also working very hard, and the people had actually a very low incidence of coronary artery disease. So that observation led to the concept of the Mediterranean diet. So with that note, I would like to say thank you to everyone.
Thank you, Dr. Seth. As you highlighted, the disease pattern is almost the same, but the presentation is different in the Indian scenario. Because we have got younger patients, they got diffuse disease. In fact, many times when they come for the surgery, there is diffuse coronary artery disease. And sometimes we wonder whether the grafts which we are doing will be functional also or not at a later stage. Any questions, please? Yes.
Thank Thank you very much for your presentation, very interesting. My question will be on the population, with the younger population, and the fact that these coronary heart disease are more frequent in this population in India than in other countries. Don't you think that one of the reasons is linked directly to the risk factors control? In some of the Western countries, there is a lot of efforts which has been given, particularly on the treatment on hypertension, to make the diagnosis early and to treat the people. Have you in India some data showing the comparison between a population which is really taken in charge, treated with some prevention activities, and the rest of the population? So my question is, don't you think that it is globally because the number or the proportion of people taken in charge in a preventive action is lower than in some Western countries?
There are efforts going on to treat the preventable risk factors. Yes, so we are trying to prevent those risk factors. So with that, we will know perhaps in 10 years what has changed. But the point I'm trying to make is that will not perhaps explain all the things. But yes, we have to first treat what we know. So we know that we have to treat hypertension, we have to prevent the smoking, we have to control the cholesterol. For us, the treatable levels of cholesterol are for LDL of below 70. We try to, in fact, bring it below 50 also. So we are acutely aware that for us, the control levels have to be much stronger. And we do know that for us, hypertension, in fact, the data is that more than 50% of the hypertensives are not even detected. When detected, more than 50% are not even treated well. Same with diabetes, more than 50% of our diabetics are not even treated well. So we are acutely aware of those lacunae in the treatment. So efforts are being made at all levels to control those known risk factors. That is being done at all levels.
Last.